you. Um, uh, One other announcement I forgot to put on our list of announcements is that it's Fellowship Match Day. So best of luck to our fellowship programs, both our current residents who are eagerly awaiting their emails and our fellowship directors who have the same butterflies in their stomach. So we're really excited to see where our grads are going to be going and who might be joining us next year. So without further ado, it's my great pleasure to introduce Dr. Jeff Louie, who's an associate professor and the director of the Division of Emergency Medicine here in our department. Dr. Louie got his MD degree at Loyola and went on to do residency training at the University of Maryland, and I learned was also a chief resident there. So we could have been tapping him for all of our scheduling conundrums over the years. You're in trouble now that I know that. Did his fellowship at CHOP and went on to do advanced quality improvement training at Cincinnati Children's. And really over the course of his career in emergency medicine has had broad spanning interests, but really with an emphasis on making care more efficient, eliminating unnecessary tests, and really looking at care in the emergency department through a quality improvement lens. He's been a number of numerous national collaborations and really has also done significant outreach with many of the hospitals that are a part of our mHealth Fairview system. I think he'll probably talk about some of that work today. The other thing that you may not know about Dr. Louie, he's just been an incredible mentor for our trainees, and want to specifically call out the work he's done with our EPAC trainees. He's really been just an incredible mentor for them as they're working on QI projects and research, and has really helped them to do some work that's been presented regionally and nationally. So I thank him for that work. And without further ado, I'll turn it over. I did want to say that I wore an R2-D2 holiday sweater in honor of Dr. Louie's Star Wars fandom, which is well known, I think. I also am a Star Wars fan, and you can see by his Zoom background, it's no secret. So welcome, Dr. Louie. We're looking forward to your talk.
Great, that was very nice, Emily. So I'm assuming you can see my slides right now? We're good, yeah?
Yep, we see them.
Perfect, all right. So quality improvement directed at general emergency departments. And thank you for allowing me to do this talk. So let's go ahead and get started. So it is the last talk of the year, and I guess I have the honor of doing that. And I wanted to make it certainly low key and fun, but very informative. So we're gonna have some fun with this. All right, so certainly thank you for all the hospital workers, residents, fellows, first line workers, the emergency department. We certainly have a mantra of continue to wear your N95, wet the surgical mask, shield. We wash our hands a lot. We keep our distance as best we can, although the ED is not designed for COVID, but it is the mantra that this is the way. And so we are very proud that we've had minimal infections with COVID so far. So conflict of interest, I will not discuss off-label use of medications or devices. I have no financial relationships to disclose. This is my son and my wife. I will disclose that my interest today, this is the last big talk for me of this year. And so I'm gonna disclose my passion for baseball, sci-fi, family and life. So certainly, you don't commit to your goal, you commit to the process that leads to your goal. And I try to learn that from every project that I do. It's not the end product of getting your last data point, it's the process of getting to point A to point B. And that's especially true of quality improvement, because you learn so much in between A and B. So our objectives, we're gonna try and illustrate the differences between quality improvement and control chart outcomes in biostatistics. And I know there's probably some epidemiologists on watching this grand rounds, and it's just me generalizing the two differences. Participants will be have a better understanding on the use of interpretation of control charts, because with quality improvement involves the processes of making change, but you can't look at your data unless you use control charts. Highlight successful QI projects performed at emergency departments. And when I reference emergency departments for this talk, we're more specifically talking about our community emergency departments out in the Twin Cities and the state. All right, one of the greatest assets a person can have is the ability to deal with failure, and baseball teaches that every day. And my son obviously is a baseball player, and this is one of the things I like about baseball because it's a hard sport, and learning to overcome disappointment is part of life. And so I like baseball because I've used that to teach him. And when he was younger, I used Star Wars to teach him. My wife and I are very spiritual, but not necessarily very religious. And Star Wars, as most of you know, it's about going to the light and doing the right thing, which is always harder attribute than going to the dark side, which is much easier. So I used to use that a lot when he was younger. All right, let's get right off to the bat. Let's talk about what we want to talk about. The notable differences between biostatistics and quality improvement. Again, Logan, if you're listening, no offense. This is just me generalizing the differences between the two mathematics, so to speak, or models. So in biostatistics, your outcomes are not necessarily determined by time, and time being, from the 1st of January to end of July, but by power. And quality improvement, you're not looking at, and quality improvement, you're always measuring outcomes over time. And the longer you watch your data, the better. And in biostatistics, you tend to have just one intervention. So you've done a randomized control trial, and you have your placebo and your intervention drug. In quality improvement, you're going to have multiple interventions, right? The multiple PDSA cycles, get your data, another PDSA cycle, get your data, another PDSA cycle. So there's multiple interventions with quality improvement projects. In biostatistics, your focus is mainly the human patient. Mr. Smith is we're gonna enroll him in our patient, we're gonna randomize into placebo or drug. And then we're gonna watch him until the endpoint of either if it's a phase 3, the outcomes. And in quality improvement, your subject is not the patient, rarely as it is. Your subject is gonna be your physicians, it's gonna be your nurses, your respiratory therapists, whomever you wanna change culture with. And there's also an environment you need to take into account. And for me, most of my studies involve the emergency department. So everyone who works in the emergency department will affect my outcomes. And that's what I like about quality improvement, because it takes care, it controls, in a sense, these indirect forces that will affect my outcomes, length of stay, patient satisfaction. The outcome in biostatistics is a p-value. The outcome for quality improvement is a control chart, and it's not a number, it's actually a figure. The p-value in biostatistics is set at 2 standard deviations versus we're looking at variations, or more importantly, non-variations in control charts, and that quote unquote p-value is set at 3 standard deviations. So some mathematical differences between the two realms of research. The river runs through in the quality improvement analogy. And I put the slide up here because one my professors used to put these slides up, and I used to be so confused what we're really talking about. But what they're trying to say is that in quality improvement, you're looking at this bubble here, and over time the bubble flows and eventually comes off the screen. But in between point A and point B, there's going to be a lot of variation of how that bubble went through the screen. And that variation could be, well, it was a very sunny day and that affects the water. It rained during your study, and so that's going to make the water more forceful. You have more bubbles. And I remember looking at that picture during class, and I'm like, what are you talking about? I think a better analogy is to look at it from the emergency department. If you walk into my emergency department right now, we'd have 3 boarders and maybe an MISC kid. And if I went there an hour later, I'd still have my 3 boarders. My MISC kid will still be there, but now I got an EMS crew rolling in with 2 kids who are obtunded from a drug overdose. And then if I look at it another hour from now, my MISC kid will be gone. I've got 2 intubated kids in the ED, and now I've got 3 more kids coming in with tooth pain. And an hour later from that, probably the patient volumes are the same, but now I've got the Zamboni people there cleaning the ED. I've got facilities fixing the tube system. And all these little factors will affect my outcomes if I look at length of stay or patient satisfaction. And again, that's what I like about control charts and quality improvement is it takes all these extraneous variables into account. So examples, obviously, quality improvement and control charts started, I don't know, 1930s, 1940s. There's two big prominent names, and I'm pretty sure there are females who probably worked on quality improvement who never would get mentioned, but Deming and Shewhart. So Deming was kind of the, he's a physicist as well as Shewhart. Both are physicists, and both derive what modern day quality improvement is today. And so I'm going to put this quick example up here. This is a 1965 Ford Mustang. Although I could have used for Dr. Neglia the Harley-Davidson, because we're going to talk about oil pans. And as you know, Harley-Davidson had the same problem about 30 years ago, where they had their motorcycle on display at a fairly famous bike show, and there's a picture of it, and I couldn't find it, of an oil pan, a pan under the bike, because they leaked. And that was one of the huge problems with Harley-Davidson was quality. And when you have a leaky oil pan, well, one, it's going to catch on fire. It may lead to an accident. It's going to increase your cost of manufacturing because now you got to fix the darn thing. And then you're going to decrease your patient satisfaction, your owner satisfaction. And so Harley-Davidson back in the day, maybe 25, 30 years ago, actually embraced quality improvement. And what they found, or what you will find, is that for every part in your car, the defect rate should be less than 1 in 10,000. So the oil pan should not be defective in 1 in 10,000 cases. And for the bolts, the oil lines, and that's how, especially Harley-Davidson, improved the quality of their motorcycles. And they're actually very good motorcycles even today. I just put this bottom part here. The defect rate is in manufacturing, it should be less than 1 million now. So that's pretty impressive. So obviously there's an overflow from manufacturing use of quality improvement and control charts into medicine. And that started probably in the 1950s, where surgeons, and this was the first published patient report, they didn't quite call it quality improvement, but where a surgeon had a group of partners and they noticed that, or he or she noticed that for type A, for whatever the surgery was, let's say surgery was, procedure A, he knows that his partners were doing all differently and the outcomes were different. So he actually set forth standardizing the equipment that they used and standardized the approach and surgical procedure, and then noticed that morbidity and mortality decreased. But certainly, what does quality improvement add to medicine? In healthcare, quality improvement is the framework we use to systematically improve the ways care is delivered to patients. And what I like about it is all these processes have characteristics that can be measured, analyzed, improved, and controlled. So what qualifies as quality improvement? And really anything that improves or standardized patient care is considered quality improvement. And I totally understand that. So in this instance, we developed some guidelines. In our emergency department, there must be about 15 or more guidelines that are all accessible. And I want to thank Mark, Ron, and Marissa for developing these guidelines. And now we're in the process of revamping them and re-updating them. But guidelines leads to standardizing your management through evidence-based medicine. So that's why I like these. It decreases the variation among either your providers or your nurses. But I also look at it as what's causing this variation, and why is there variation? That's what interests me in quality improvement. Is that, well, it's how people think and how people do things. And well, why is that? And how do we change culture? So this is the way my brain kind of works sometimes. I have a person with the topic skin abscesses, and I'm observing like, man, the people I'm working with are doing things differently. Here's Louie, he can't decide which way to go. Here's Pablo, who's the most flexible of all of us, who can change and adapt quickly and do the right thing. And then we have someone else who doesn't quite know where to go. And so you notice these variations. And my next thought is, well, we should try and get some historical control data. Let's pull some data and look at skin abscesses, and let's see who's taking care of them. And for these particular studies, I like to have the doctor's name because obviously they're the ones who have the variability. The other thing that we found is that let's send a survey, and I did this with Erin Belay and her study for pain control in ED. And let's send a survey to the physicians, and not just the physicians, the nurses, and not just the ED nurses, the flow pool nurses, and not just them, the EDS folks. Let's find out what are potential barriers for this particular topic of the management of skin abscesses. And so, and when you do your surveys, you give a couple examples of kids who have fever, no fevers, different ages, and you see how there's variation. Some people like to sedate with IV, some people like to use intranasal, some people like to, and then this is what I noticed, not at this facility, but there was one physician where I used to work at who used to sedate, do an IND, and then admit the child who was afebrile. I never really understood that. So you look at your data, and then you make a plan, and you do your data from your survey, and then you do your first intervention. And then you roll it out. And then you have your prospective data, and you look at the data again, and then you're gonna see if you're accomplishing what your goals are. So in this instance, and this is the famous plan, do, study, act, is you have an idea. You gotta get your interventions, and that could be just 3 or 4 at the time, or maybe 1. And you carry out your intervention, and then you observe your data, get your data back, and then you plan your next modification or do your next survey to find out, well, what did you like about the first intervention? And usually what happens is when they teach you in class, you do 1 intervention at a time, but in general, you do multiple interventions, look at your data, analyze your data, do root cause analysis, maybe send out another survey, and then you plan your next intervention. So this is where you get the famous PDSA cycle, and then these other PDSA cycles. Study you do your intervention, get your data, do your intervention, get your data, do your intervention. Obviously, you're studying before you roll out your next intervention. And I kind of like this slide because it is definitely, as all research is, it's an uphill battle. It can wear on you after a while. But there are some studies that may go through 10 PDSA cycles to finally achieve their patient satisfaction goals or compliance with the management of septic shock. It may take that many cycles. And that's why in quality improvement, time is probably the most important aspect of quality improvement, because you want to see over time that you achieve your goals and that whatever your number is, your compliant, whatever your bar set is stable over time. So when you do quality improvement projects, you may have 6 months to 12 months of historical data, but if you only have 12 months of intervention data, that's not long enough. You need 18 months. Most people say you need 18 months to 2 years worth of data to see if that data is actually stable enough. Understanding the math. All right, so again, for the epidemiologist, I mean, no offense, this is just me talking in my Louie way. I have on the left here, you have a sample 2 test. Here's the math. You have your mean for group 1 and your mean for group 2, and a difference of 0.7, and through lots of math, you're going to develop, you're going to finally find out your standard error, and through your standard error, you get your p-value. For p-charts, again, there's math involved, and I remember doing both of these. Logan, I've taken your class, doing all these by hand, and I remember when I took my quality improvement class, we did this by hand, and eventually on an Excel spreadsheet, so that was just lovely. But the p-value does not stand for your traditional biostatistics p-value. In this situation, it means the variance, and we're talking about a control chart. And that's just the math. So there's math involved, and again, Schubert derived all the mathematical calculations. And so again, comparing it to statistics, we're talking about 2 standard deviations. This is a normal distribution curve, which is here, which we all know, and it's also over here for -2. The occurrence traditional outcome is a p-value, which is set at 1 in 1,000. When you do control charts, we're talking 3 standard deviations, which would be your quote-unquote p-value, so to speak. The natural occurrence is 1 in 10,000. So for something to happen abnormally on your control chart, when you look at it, the likelihood happening just by chance is about 1 in 10,000, and if that's possible or not. And again, in control charts, we don't use p-values. In statistics, you get an output, right? So you use SAS or SPSS or whichever program you're using, You hit return or calculate, and your output is a p-value. It's like, yes, 0.001. In control charts, literally, it's a figure. So in quality improvement, you can't do that really well without knowing your data and looking at the control chart. It doesn't output p-values. It's going to output a figure for you. And so here, excuse me, we have an example of a control chart. Control charts are always going to have a y-axis, which is your outcome variable. And in this situation, it's patient satisfaction. This is your x value, and it's time value, right? X-axis is always based on time from your oldest data point to your most recent. So week 1 was maybe 3 months ago, and week 4, the patient satisfaction was about 75%. If you're going to do patients, so sometimes you can look at, well, we've got 20 stroke patients, and let's see how compliant we were with the stroke bundle and time to the intervention lab. This will be the patient who came in the longest ago, the oldest, and this is your most recent patient, but it's always time oriented. The little dots, I'm going to use a very scientific term, dots are these little square dots here. Each dot is called a subgroup, and each subgroup represents a week in time. In this instance, is a week. So week 4, this subgroup, or dot, is 75%. The week later, it's about maybe 77%. I don't know, 76%, and obviously this is the mean. The mean is called the center line, and the mean represents the average of all these little subgroups. And when you look at a control chart, you want it to go up and down, up and down. It's kind of like VTAC. Here's narrow VTAC, there's wide complex VTAC, up and down. And when you start seeing patterns, that's what we call special cause variation. And the likelihood of this happening naturally on its own, so all these dots above the center line, is less than 1 in 10,000. So it takes a lot of effort or a miracle for something to happen by chance to have an unusual pattern. All right, and so again, just for reference, this is the upper control limit, this orangey color line, and this purple line is called the lower control limit. So those are the main components of every control chart that I look at when I either read manuscript or even my own data. And so in this figure, it's all the special cause variation. So all those little things that you look at a control chart, and if you recognize a pattern, the likelihood of this happening on its own is less than 1 in 10,000. So in this control chart, this is your y-axis, and this is your x-axis. The C represents your center line, just for reference. And in this figure, they actually divided up into sections, the C zone, the B zone, and the A zone. And what this represents from here to here in the C zone is 1 standard deviation. This is 2 standard deviation. This is almost 3 standard deviations. And so when you look at the control chart, the first thing we look for is, are there any points or dots above the upper control limit or lower control limit? And again, the likelihood of happening is less than 1 in 10,000. Rule 2 is 2 to 3 dots in zone A or beyond. So 2 in the red and 1 in the yellow is not good, or it could be good depending on what your intervention is. Rule 3 is 4 out of the 5 in the zone B or beyond. Zone 4, 8 or more on one side of the center line. So again, when you look at your control chart, you should have dots above your middle line and below. When they're all clustered below the line, below the center line, that's something that's called, again, something called special cause variation, and that should interest you, and hopefully it correlates with your type of intervention. This is rule 5, 6 dots or subgroups all going up or all going down. And rule 6 is 15 consecutive points close to the center line. So basically clustered here, 15 points. And those are the general rules that we use when we look at control charts. And when you see these patterns, again, you're looking at a figure, you're seeing these patterns, those represent special cause variations. And you should go back and find out what happened during those periods of time. So I used a control chart to demonstrate what happened with COVID. This is actually a run chart, I apologize. So the y-axis, and this is our data here. Y-axis is ED visit per month. This data is like 2.5 years. The mean visit is 1341. Again, this is a center line. In 2018, we saw 16,204 patients. In 2019, we saw 16,566 patients. And right here is December of 2019 is when the news came out about the darn COVID virus. And right now, you even recognize as you look through this run chart is that the natural pattern is gone. And that's interesting. In December 19, we had the highest volume that year. And probably a lot of RSV, a lot of bronchiolitis. But as the state was preparing for more implementation of COVID rules, stay at home especially, and parents being aware that this virus is a bad thing, we don't want to be exposed ourselves, and the lockdown of schools and whatnot, our volumes just dropped to a low of 550 a month. And if you were to extend these dots out, if I have October, November, this would be a special cause. So it's 8 dots below the center line. But you can tell how much aberrancy the chart, it just doesn't look right. There's no more ups and downs variation, which is called common cause variation. This is abnormal variation. And again, root cause analysis, if you didn't know what's happened, you figured out that it was COVID and the stay-at-home order took into effect. Baseball. So again, disclosure, my son's a baseball player. Unfortunately, did not get to play varsity for last year. He's now a senior. This is summer ball, I think of this summer. They're trying to social distance as best they can. So my son is number 31. And I was looking at this picture about a week ago as I was putting my talk together. And I'm like, oh my gosh, why is he batting lefty? He's not a left-handed batter, but he likes to joke around that he's a switch hitter. All right, so implementing QI at community EDs. Why do we even care about our mHealth community EDs or any general ED throughout the community, throughout the state, throughout the country even? Well, we know that about 85-90% of kids are seen in general community emergency departments. We know that data, and I'll show you the references in the next slide, that when kids show up to general community EDs, they're most likely to get a CT scan. As a matter of fact, 80% of CT scans are performed at community EDs. If you show up with abdominal pain in community ED, you're more likely to get a CT scan. And national databases have shown that children who show up to community EDs have more likely to get chest X-ray and even testing. So I thought about this slide, and before my second screen shut down and I had to reboot the whole darn thing. But in the state of Minnesota, there are about 400 designated trauma centers in the state of Minnesota. There are 5 pediatric trauma centers in the state of Minnesota. There are only 2 pediatric trauma centers that have full complements of pediatric surgical subspecialties as well as medical subspecialties. And those 2 hospitals are us, University of Minnesota Masonic Children's Hospital, and Mayo. So you can imagine, right, these kids showing up to community EDs who have no pediatric affiliation with pediatricians, that they're going to do their best, what they believe is doing the best for their child. But we're now learning that they're probably a little more aggressive than what we would like them to be. So on this slide, and this is just CT scanning in general. This is after the PCARN head injury guidelines, and there are CT rates, and these are blunt injury, head injury. CT rates about 20%, and then pediatric ED is only 10%. If you present to a general ED, you're likely going to head CT is 42% versus 21% in kids, 37% for abdominal CT, and 15% in a pediatric ED. If you look at bronchiolitis, the likelihood of getting a chest X-ray is 67%. Versus 42% in the PED. And I would actually say our Masonic ED, it's much less than that. It's probably about 10 to 12%. Steroid use is higher in adults. Interesting, albuterol use is a little bit less than adult ED, but I don't blame anyone for wanting to try albuterol in a bronchiolitic kid. But I think this slide definitely demonstrates that there are improvements that need to be done at community EDs. And so this is basically these 2 very well-known peds emergency medicine physicians who looked at national databases throughout the country. And basically the data shows that we need to develop collaborative care in community EDs to enhance reliability and consistency in pediatric emergency care. So this is a study basically done at community ED in Seattle. This is 2017 from Jennings. And basically, again, head CT rate over time, and they were able to reduce their head CT rate down to what their goal was, which is less than 20%. And then the backstory of this is that this general ED actually had pediatricians who were hospitalists, who were not in the ED, and they used MOC for credit to entice the pediatricians to help the emergency department to reduce their head CT, which is good, and they did a great job. A little more backstory is that Rebecca trained with 3 folks that I did my AIMS course at in Seattle, and I discussed my idea, and I remember them saying, "Hey, that's actually kind of nice. We should think about that." And they were actually got their data out before I got my data out, but that's the backstory. All right, reduction of pediatric head CT utilization at rural emergency departments. And I did this study, and thankfully it just got published not too long ago with Joel Fano, Twee and Hai, who are both medical students here at the U, sisters, Tara Holm, Ryan Shanley, and Dr. Furnival. And actually, it's funny, it didn't save this. I actually made a small edit, and also on Dr. Kelly Dietz. So you got to know your audience. And so Fairview Lakes is way up here, and we're way down here. It's about a 45-minute drive. Their volume is about 40,000 plus minus a year. They see about 5,000 kids a year, less than 18 years of age. They are a level 3 trauma center. And at the time of the study, they don't still have pediatric subspecialty services available. They do have, I believe, a pediatric nurse practitioner who does inpatient stuff, but there are no resources for them at all. You can imagine yourself out on an island without having pediatric expertise help. Their EDs is, they have EM and family practice trained residency physicians there, and they also have some physician's assistants. And so, every quality improvement should have a key driver diagram, and the outcome for us was to reduce head CT rates with our balancing measure of missing clinically important traumatic brain injury. And so clinically important traumatic brain injury is based on the study from a fairly famous study of Picarn and Koopman. And their main outcome for not doing head CTs, and this is what they didn't want to miss, are kids with CITBI. And that is defined as kids who are going to die, kids who need OR procedure, kids who are intubated, and kids who stay 2 nights or more in the hospital from their head injury. And so those are the things that we never want to miss, and those are things that drive us to do head CTs. But obviously with their study, we found out good rules on when to do these types of, when to do the head CT. So in the key driver diagram, basically all these arrows, the primary driver is your main driver to decrease your head CT, and then you have the secondary drivers, which relates to the first primary driver. And so, creating short didactic talks was one of the things we created, and I used that information to teach the staff. We created the PCARN. We created head injury guidelines with PCARN publications that we posted at every computer site and so on. And so it all helps keep your thoughts aligned. And so we set up some ground rules. I think this is important when you work with community ED. I certainly did not want to walk into the ED and say, "Hey, I am your pediatric expert, and this is how we do it." That I knew was going to fail. And I've been involved with Lean 6 projects, doing a very similar improvement and efficiency. And when we rolled it out, there were physicians literally crying. They're so upset. And it had to do with how we rolled it out. And it had to do with not even preparing these people what we did. And so learning from those lessons, when I went to Fairview Lakes, I decided, well, we're not going to do that again. And so I worked with Dr. Alfano about what's the best way to roll out a plan to change culture of decreasing head CTs at his facilities. And a lot of the rules were made, kind of guidelines were made. And one of them is that everything that I did, everything that I developed, handouts, PowerPoint talks, data that we got, he would review them first and edit as needed. He didn't really decline anything. He would, rewrite things because I'm a bad writer. And then also that I didn't want him to develop new meetings for me. I was able to fit myself into his scheduled departmental meetings, and I kept them short, maybe 20 minutes or so. So developed a talked about the head injury guidelines. We talked about radiation risk, talked about what we don't want to miss, is this clinical important traumatic brain injuries. And I always left time for Q&As. I always left time for the doctors to ask me questions about, well, how would I manage this, how would I manage that. We made handouts which educate the staff on radiation risks and how to use the head injury guidelines. And they also asked me to develop dot phrases to blow into their charts for medical decision making, which I thought was actually, and I didn't even think about that. I was like, oh, that's a great idea, which we did create, and we'll see the timeline by the second time I met with them. And then being very transparent with the data. I showed them Dr. Alfano first, their head CT rates, and then I de-identified all the ED staff, and I showed the head CT rate by de-identified data, but I gave each name to the ED director because, as we'll see, there were some outliers that he would have to talk to specifically. So this is our head injury guidelines that we've developed. I don't think I had enough time to go through it all, but what I do like about it, and it's cohorted into less than 2 and older than 2. So if you have a less than 2-year-old kid whose GCS is normal, who does not have a hematoma on the scalp, who had no loss of consciousness, who did not have a severe mechanism, and whose parents state that their kids acting normally, what I like about this study is the negative predictive value of a clinically important traumatic brain injury is 99.9%. And that's huge, and people can understand that concept. And this is what we're talking about, the kids who are actually visiting Fairview Lakes. The majority are these kids here. They were scanning kids who were very well appearing. So they're older than 2, same thing. Obviously, we're not, if your GCS is not normal, you got to get a head CT. That's right. So the risk is 4.3% of a clinically important traumatic brain injury. But if a kid has no loss of consciousness, no vomiting, the severe mechanism was not a severe mechanism, and did not have a severe headache, the negative predictive value was 99.5%. And so this is a dot phrase I made for them. This is for the under 2, just over 2 years of age. It basically kind of blows into their chart, and it states that the patient has no mental status, GCS is 15, no evidence of basal skull fracture, no loss of consciousness, vomiting, the mechanism imaging was not severe, no basal skull fracture, no headache, and negative predictive value again is about 99%, 99.95%. And then I also said when I was doing my talks, it's like, and I think this is kind of like an eye-opening experience. It's like, if your kid that you're managing looks like this, you probably don't want to do a head CT. If anything, just watch them for 3 or 4 hours post-injury. And if they still look great, they're not deteriorating, then those kids are going to do fine. And that was kind of the eye-opening experience. Like, oh man, these kids really do look well. I also threw in 2 other caveats. I said, if this was your kid who had this mechanism of injury and they looked this well, would you scan? Knowing the risk for radiation. And then again, you see there's silence because they were thinking about it. There's also another caveat that I didn't put on the slide, was there was a Swedish study that looked at ionized radiation in kids who were exposed by radiation who had hematomas, or hemangiomas, excuse me. And so what they found in Sweden, because they track all their kids until they're, forever, but they also tracked them when they became recruits in the military. And what they found is that the recruits who did have a history of hemangioma and the recruits that had multiple doses of ionized radiation compared to the recruits who had 1 dose of ionized radiation, the recruits with multiple doses of radiation had lower IQs. So I tell that to parents and they go, huh, yeah, my kid does look well. I don't think we do need a head CT. So this is our data. I'm kind of going through this a little bit fast because I'm realizing I'm talking way too much. But I predicted when I met with Dr. Alfano is that their head CT rates could be about 50% without even looking at the data. And I was pretty close. It was actually 40%. And then through time and effort, we were able to reduce to 28.1%. So I met with Dr. Alfano back here in January, and then we discussed the plan. And then I literally went out there once a month for the entire intervention, almost the majority of the interventions, if weather would permit. But this is the timeline. And so site 1, site 2, site 3, site 4, 5 visits, and site 6. And what you see is there's actually a special cause variation. And what's nice about the data is that it shows that, one, this is special cause variation, and the likelihood of this happening just by chance is less than 1 in 10,000. And so I would argue that it was all from these multiple interventions that we went to visit the emergency department. And then I came out a couple more times to make sure that the data was stable over time. And we ended the study in June of 2014. And so we were able to reduce it by 14.1%, which is a difference of, has a p-value of 0.0004, which is like, yeah, cool. But then when you look at hardcore QI scientists, they're gonna say, well, what's your slopes? And did you compare the slopes? And we did compare the slopes. The control data was basically a flat line, and our intervention data was sloped going down, but we just didn't have enough data to show that there was going to be a statistical significance. And basically that meant carrying out the study for another year, and we just didn't have the manpower to do that. But what is nice is that after we started the intervention, the odds ratio shows that there was probably 1 less head CT per month over time, which is amazing. So you can imagine if we kept on going, how many more or less head CTs would have done. And we talk about providers, and so I made a funnel chart. And funnel chart basically is a control chart. This is a P type of funnel chart, but it addresses data through the folks who not only see the most, but also order the most head CTs. Over to your right are the people who saw the least amount of kids and ordered the least amount of head CT. So for this person, they probably saw 2 kids and they ordered 1 head CT. And so for these guys here, or gals, these are significant outliers, right? Both their data points are above the upper control limits. And so basically what this tells me is that these people were not even gonna budge on ordering head CTs. They were just gonna order regardless of how we went out there and tried to change culture and showed them their data. And it's interesting because when at Masonic, there are nurses who also work at Fairview Lakes, and I was talking about my study, and I didn't even mention names, and they go, oh, I bet it's Dr. So-and-so and Dr. So-and-so. They always order head CTs, and so that definitely proved my point, is that those 2 were definitely outliers. And so I gave that data to Dr. Alfano, and I left it up to him to discuss with his providers individually to see if they can deduce their head CTs. All right, so this is AJ again. This is AJ here, number 31, and this is his best friend, number 13. These guys are 2 peas in a pod, and it's nice that they both have prime numbers on their jerseys. So now we're going to talk about bronchiolitis. And the folks that helped me were Dorothy, Sarah, Ashley, Faith, Joe, Alfano, Nick Joubert, who are both from Fairview Lakes, Ryan's our dietitian, and Kelly Dietz, and then of course myself. And these were all former EPAC students, and I want to thank them for all their energy and support and pushing me to continue with the project. So again, we developed this key driver diagram. This study actually had a little more insight because I learned from my mistakes on the head CT study. So we actually surveyed all the staff to find out potential barriers before we rolled out our interventions. We developed infographics or handouts on AP guidelines. And again, all these efforts were made to drive down our outcome, which is reduction in chest CTs, in chest x-rays, utilization at Fairview Lakes. We are lucky to have 2 site champions who actually provided the energy when we were not on site to help discuss chest x-ray utilizations or even testing. We made a handout for parents on this study and to discuss, for the parents to read, to understand bronchiolitis, because a lot of bronchiolitis, you just kind of sit there and the parents just kind of watch your kid. And so this gave parents information to hopefully provide shared decision model with the provider if the provider wanted to do more stuff. Our balancing measures were bounce backs, because obviously we're asking the providers to do less testing, give less treatments, and we're hoping that the kids didn't bounce back at any higher rate than they should have, and they actually did not. So again, same ground rules, but this one we had 2 site champions. Again, I went during their department meetings, which is every second Tuesday every month at 7:30 in the morning to 9 o'clock. And I would do my talks, discussions in a 25-minute time period, sometimes even less. We discussed radiation risks. We discussed the AEP guidelines. We created the handouts, which we'll see in a second, and they were also posted by computers. And we made the parental handouts where hopefully the goal was, once a patient was kind of tentatively diagnosed with bronchiolitis, that these parents would get these handouts. And then the goal was to decrease chest X-ray rate, as well as all testing, all use of medications as best we could. So this is a sample of the provider handout that actually Faith made, and who I would give lots of money to make more handouts for me. But in this handout, it discusses what should and not be done based on AP guidelines. And then we also include differential diagnosis. What are the risk factors for more severe cases for bronchiolitis? So we try to put as much information as we can to help educate, not only bronchiolitis, but what to look for, how to diagnose it, so to speak. And again, everything that we wanted to do to learn as much as possible about bronchiolitis, but also change culture at the same time. 2 things have changed. Obviously, we don't do deep suction anymore, although that is controversial, I will admit. And also, back in the day, we were asking them to still think about doing urines in these kids, because that was a general consensus at that time. But now we know that kids with bronchiolitis are not at higher risk for UTIs. And again, what not to do. Again, we tried to enforce that. This is the parental handout that we gave. We actually, every handout was laminated so that it could be easily, quickly cleaned. And these were distributed to parents as they were sitting and waiting to go home, because as we know, just nasal suctioning, oral challenge, and watching vitals is all you really need to do for most cases of bronchiolitis. So our data, which was actually presented at Press 2020 virtually as an oral presentation by Sarah and Dorothy and team. The initial chest X-ray rate was 75%, and when Dr. Alfano saw this, he almost blew a gasket. He almost kicked me out of the room. But this enforced the message that they needed to do better. And so historical data here, and by the first season, and we're talking seasons, right, a very short period of time, we reduced it down to 33%. And in season 2, it was interesting because we offered to go out again and give them more handouts, do more Q&A sessions, and the site champion said, nope, we got this. And which was interesting because that's never happened to me before, but that was awesome. And I just reminded them through emails about a week before their standard department meetings to remind their partners, the staff, to do less chest X-ray, less testing, to remind them to look over the AEP guidelines and so forth. And so we were able to reduce it over 2 seasons from 75% down to 15%. And everyone talks about these outliers here, but you got to remember at the end of bronchiolitis season, you're seeing less patients. So I guarantee you this is in May of 2019, they saw 3 patients, and 2 of them got chest X-rays. Versus here, we're talking 20 to 30 cases with bronchiolitis with less chest X-rays. So it's just the way the data shows that we had so few patients, but unfortunately, they got chest X-rays. So we made pre-survey surveys. Before we started the study, we did a survey, and after the study, we did a post-intervention study survey. And this is the case that was presented in both situations. It's basically a 4-month-old who presents with 1-day history, very common presentation, low-grade temp, heart rate not bad, breathing 36, pulse ox 95%, maybe some coughing, maybe some mild retractions, maybe some slight wheezing. And before we did our interventions, the chest X-ray rate for a very well-appearing kid was 15%. And after we were done with our study, it went down to 0. And overall, more importantly, is that most of the doctors would say, yeah, we probably won't do very much of anything besides nasal suctioning and oral challenge. And that went from 38 to 89%. So overall, we were able to teach them to do less, which was good. And then we had the foresight and asked them, wow, let's ask the providers what really helped. What was the what did they feel was best intervention that changed their mental model, that changed their culture? And interesting enough, it was the Q&A session and the brief PowerPoint presentation. 67% actually liked that. And the handouts had some effect, maybe 55%. The site champions, encouragement from the medical director, was 44%, as well as the parental handouts they thought was slightly effective, 44%. So what we learned a lot from that, from this second study, is that this, and I think it's really the Q&A sessions. When I call the ED providers and the site directors out there, the medical directors, they actually appreciate the Q&A sessions. So I think moving forward, as we help integrate into the mHealth system, is to do more of these one-on-one, do these group sessions where they can just ask questions. Because I think providers are more likely to learn more when they can ask specific scenarios that they've come across. All right, so we've got a little bit of time left, and this is real life QI project, helping my son's batting average. And so here's a key driver. And yes, I actually thought about this. When you're watching summer baseball, you got a lot of time to think about stuff when your son's not at bat or playing that particular day. And so the main outcome was to increase AJ's batting average. And there was my primary driver was teaching him to let the ball travel into your zone. Teaching him to use the whole field, because as we all know, Rod Carew and I can't remember the other people's names, but if the more likely you use the entire baseball field, the better chances you increase your batting average. And this is for my son, the ding dong, because I want to hit the long ball. I'm like, well, ding dong, they're catching it. So we had to really focus and change his culture to hit more line drives and grounders, because if you use line drives and grounders and use the whole field, your batting average is always going to increase. And then more importantly is his visualization. I was just teaching him to visualize his swing, his strike zone, trying to understand the catcher, trying to understand how the pitcher throws, and more importantly, understanding the umpire. If the umpire calls a strike that's an inch off the plate, when you're catching, he's going to do the exact same thing when you're at bat. And I was like, oh yeah, that kind of makes sense. Through all these efforts though, and if Kareem, if you're listening, less batting time off the pitching machine. Most people would argue that offsets your timing. And so if you don't use the pitching machine, you're gonna improve your eye-hand coordination. So a lot of these things I use in an effort to change my son's mental model on batting. So believe it or not, I have a P chart because I would try to keep track. I know it sounds bad, of my son's batting average. I didn't get to make all these games, so I had to ask him, so how'd you do with this game? And this is just a rough estimate. I was trying to be like, the parent who doesn't say too much about his son's baseball swing. And he was batting about 200, 210. And then I finally got fed up. I said, dude, you're much better than this. You're a much better athlete than what you're showing at the plate. And so we started the QI intervention of everything we had talked about. And once we started the intervention, his batting average on average went up to about 450. And I guarantee you, by the time he was done, his last game, off of left-handed pitchers, he's a right-handed batter. He was seeing the ball so well, his batting average was about 750. It was amazing how well he was doing. So I'm going to show this video if it works. Please work. Here we go. This is the last game of the year in a tournament to win the championship. And that was his home run. That was just a proud moment for a parent, but even I think my son was even, well, I don't know who was more proud, but that was just an amazing swing off the left-handed pitcher. And of course, then fall ball comes, and we all have kids, and I backed off on pushing him to work on his swing, and he swung for about 5 minutes, and then you can tell he's on his phone, which is what all kids do. So that was fine. But I think quality improvement, if used effectively, can help not only your own son, but implement it in the community EDs will change a lot. And we have a lot to do with our mHealth ED system, which I think we can do with the proper resources. So I want to thank certainly Dr. Neglia and the Department of Peace for sending me out to Cincinnati. Good times. I didn't even know when you fly into Cincinnati, you have to fly into Kentucky. Whew, that threw me for a loop, but I spent about 9 months, once a month out there, and learned a lot. Certainly want to thank Amanda and Brian and Elizabeth for all their efforts in our research endeavors here in our division, and all the EPAC students and residents who've helped me and encouraged me and given me strength to do quality improvement projects. And of course, I want to thank my parents. So that's it. I try to keep it as short as possible. I want to thank everyone.
Thanks very much. That was really great. We have time for, I think, 1 or 2 questions. Tina Slusher, one of our faculty who does clinical work mostly over at Hennepin, was curious if you've had any follow-up on that head CT rate study.
Yeah, you know, it's funny. When we presented this data at the IHI, which is a very prominent quality improvement national conference, and we present our data, and that's one of the first things that even the president showed up, and that's the first question he asked. Well, what's the current head CT rate? And I'm like, you know, I said I don't know, because we don't, you know, once the study ends, we don't continue to track the data. But after doing a couple quality improvement projects through the mHealth system, I think I found a way to indirectly measure these outcomes. And so that's our next step, is to continue to look at the chest X-ray at lakes and the head CT rate at lakes, and using a very indirect measure of those outcomes, and without reviewing hundreds and hundreds of charts for inclusion and exclusion criteria. So that's the next iteration, and that's something that everyone asks about your quality improvement project. Well, is it still going? What's the rate now? I'm like, I don't know. I don't have the money or the resources to know that data right now. Yeah, it's a great question.
Yeah, I noticed on your CV that that's something you've been working on, is just getting at the data. And I think that's been one of the big challenges when trainees have wanted to work on quality improvement projects is, you know, we know it's in there, but digging it out of the EMR can be a challenge,
Right.
some pretty labor intensive.
One data, you know, we also did looked at 4 Fairview sites at reducing their neck CT rates, which I didn't have time to show, but we literally had to hand clean over 6,000 charts to find the kids that met inclusion criteria. We're talking about neck injuries. That's kind of hard to decipher by just looking at CT rates. Yeah.
Wow. Well, thank you so much. That was a really great review of control charts and quality improvement methodology. And now I realize that we can also talk about baseball and Star Wars, because baseball is big in my house too. So.
Oh yeah, you know what? I will. I've offered to Kareem. My son's graduating. I am available to be a baseball batting coach for sure. Anyone, anytime, I'm there.
All right. Wondering about the infographics being available at other sites as well. We have a question from Dr. Falsey, one of our hospitalists.
So how do we develop them, or?
If someone wanted to use them at another site, where could they find these beautiful infographics?
Oh, certainly we have the ability to reproduce, especially the bronchiolitis stuff. We have the hard copies, and we can obviously have to modify them to current literature, but yeah, we can certainly develop those for you, anyone.
Great. Well, thanks so much. Really appreciate it, everybody. Happy Hanukkah if you celebrate. Happy New Year. Happy Match Day for those who are getting their match news today. And just wish you all well as we wrap up 2020, and we will see you again for grand rounds in 2021. Thanks, everyone.
Bye-bye. It stops here. There we go.